So in the next 30 minutes, what I'm going to talk about is I want to review some of the current trends in palliative care and also introduce you to the gold standard framework. And these are some tools used to help us identify patients that would benefit from a palliative approach, and also gives you the tools on managing these patients once you've identified them. So it's always good to start with patient. So I've got 3 patients that I'm going to introduce you to. And what I want you to think about is, would you consider introducing palliative care for these patients? Okay, and there are no trick questions. I really want to know whether you would kind of think about palliative care for these patients. So one is Mrs. Shum. She's a 48-year-old woman who's come into your practice. She presented with abdominal pain and weight loss. You do a series of investigations. You eventually do a CT scan, and she has a mass at the head of her pancreas, and you also see liver mets as well as lung mets. You refer her to the surgeon who does a biopsy, and it comes back positive for pancreatic CA. She's obviously not a surgical candidate, and she's now just awaiting assessment at the cancer center. So she hasn't seen anybody. She hasn't seen medical oncology or radiation oncology. She's married. She has 3 children between 10 and 15. So how many of you would introduce palliative care for this patient? No? A few. Okay, so think about that. So we're going to go to the next case. It's Mr. Harris. So this is a patient in your practice who's a 70-year-old gentleman with COPD and hypertension, as well as diabetes. He was recently discharged from hospital with his COPD. This is his second admission to hospital. He's currently on home O2. He needs a considerable amount of help. His wife is helping him with his ADLs. And he has, his wife is his primary caregiver. He only has 1 son who lives in the US. So would you introduce palliative care to this patient? So how many would say? Oh, still not too many. Okay. So the third case is Mrs. Grant. So she's a 60-year-old woman with MS who comes in for her annual physical. Okay, so her disease has been generally stable. She currently walks with the support of a walker. She's managing her ADLs. Her weight's been stable, and she continues to work in her family business as doing some accounting there. So would anybody introduce it there? So no one in this case. Okay. So think about these 3 cases as we go through the next few slides. So I know that this is a cancer care for primary care, and the last 2 cases were sort of chronic disease, but I can't really talk about the changing face of palliative care without talking about chronic disease, because really that's our palliative tsunami that's coming, right? If we look at our current population, seniors make up the fastest growing population. So in 2009, 14% were over the age of 65, and by 2036, we expect 1 in 4 of us to be over the age of 65. And so why is that important? Is because 41% of Canadians, seniors who are over the age of 65, have 2 or more chronic conditions. And 75% of all the deaths that we're having are in this age group, the patients that are 65 years and above. And when we look at the leading causes of death, cancer makes up 25%, heart disease makes up 35%, and lung disease makes up about 10%. And what's interesting about that is that, so end-stage heart and lung make up 45% of patients who are dying, and cancer makes up 25%. But when you look at CCAC resources and who's using the end-of-life care resources, it's mainly the cancer patients. So there is a gap in terms of resource allocation. These people aren't getting the supports that they need. So if we look at our current state, where we're at, 40% of terminally ill cancer patients visit the emergency room in the last 2 weeks of life. If we look in the last 6 months of life, we have 84% that go to the emergency department. And if we look at number of visits, 30% of those patients have 2 or more visits to the emergency department. We look at long-term care, 41% are going to the emergency department in the last 6 months of life. And approximately 70% of the deaths that are occurring in hospital. Yet when we do the polls, most patients want to die at home, yet we're not seeing that happening. So 96, so when we look at things like advanced care planning, we know the public wants to talk about advanced care planning, yet very few people have advanced care plans in place. So so this is our challenge, right? So we have patients that want to be cared for at home and want palliative care. We've got a healthcare system. There's not enough of us in palliative care to manage this. We have a healthcare system that wants to reduce cost. And then we have this growing population that we need to start managing. And there's greater pressure on you as the primary care physicians. So there are other trends that are sort of changing how we look at palliative care. And the biggest change came in 2010, and it's this concept of palliative care early on in disease trajectory. So in 2010, there was a landmark study done where we took lung cancer patients, and we divided them into two groups. One that got regular oncological care, and another group that got palliative care along with the standard care. And so what they found in the group that got palliative care right from the time of diagnosis was that they had reduced symptom burden, less anxiety and depression, less caregiver burden, better quality of life, better choices in terms of treatments, or less aggressive treatments. And in the end, these patients actually lived longer. They lived 2 months longer than the other arm. So this was sort of the changing sort of phase for us in palliative care, because now we're starting to look at the impact that palliative care actually has on these patients. There have been, since 2010, there's been a number of other studies, and we also know that it has a huge impact from a systems perspective, that if we introduce palliative care early, we have more appropriate referrals to palliative care resources. So those end-stage heart and lung disease, maybe they would get those resources at CCAC. Decreased ED visits, admission avoidance, and there's actually been studies looking at measurable hospital savings. So when this study came out, ASCO took it very seriously and came up with an expert consensus saying that their recommendation that combined standard oncology care and palliative care should be considered early in the course of illness for any patient with metastatic disease. And so now we're adopting this. So we're adopting this in the cancer world. So if you look at our illness trajectory, you'll see that psychosocial oncology and palliative care is initiated right at the beginning of diagnosis. And even the chronic world, patients, people in the field of chronic care are also endorsing this. So the Heart and Stroke Foundation, for example, is taking this data very seriously. And they recognize that we're not doing a good job of having these crucial conversations and referring these patients at the right time to the right place. And so they've developed their own version of this diagram in order to include them as part of this whole early on in disease. So that's a challenge. So when ASCO came out with this, I think my referral rates went through the roof, right? Because it seems like, because the way the study was actually conducted, it was a referral to a palliative care team, right? And so, but what is it that these palliative care teams are doing that are making the difference? And I think really we've got to kind of move away from this whole concept of palliative care and a referral to palliative care and really look at this concept of a palliative approach. So when you look at what I do on a day-to-day basis, I'm screening for symptoms, I'm having crucial conversations, and I'm referring to the right people. It's not rocket science. It's something that we all should be doing, right? And I think that's the key thing. There's not enough of me. When you look at palliative care physicians across the province, there's not enough of us to deal with this tsunami. We're going to deal both with chronic care as well as oncology. And so we need a greater engagement with the rest of the healthcare system. That means you as primary care physicians, it means oncologists, radiation oncologists, it means the internists. We all have a place and a responsibility in managing these patients. So like I said, if we break down what these studies and what these palliative care teams do, we're identifying these patients, we know who they are, and once we've identified them, we're discussing prognosis, we're having conversations about illness understanding, goals of care, we're screening them for physical symptoms, anxiety, depression, we're connecting them to the right social supports, and we're consulting and referring them if we need to, if I need to send them to a dietitian, a social worker. So really, this whole concept of a palliative care approach is that we're all responsible. So it's a palliative care approach to caring should be practiced by all providers and at all settings with anybody who has a life-limiting or life-threatening illness. And so this is the new model. So this was actually came out of Erie St. Clair. So they actually sort of started this model where really what we're trying to do is level one. We really want to get level one. That's all of you guys engaged and really be able to manage these patients yourself. And then I would be, the second or third level when it comes to care for these patients. So I think we're kind of moving away. So when I put those 3 cases up, in the front, I wasn't asking whether it should be a referral to palliative care, really. What I was asking, would you actually initiate sort of this palliative approach to care? Do you think these patients would benefit from it? So we're kind of trying to sort of have a culture shift where we stop labeling patients as palliative, that patient is palliative, but really start saying, do you think this patient would benefit from a palliative approach? So the things that I talked about, do you think that patient would benefit from those activities? The other thing is I think palliative care is often seen as end-of-life care, and I think sometimes with the case 1, where she's just been initially diagnosed, I think there's a lot of fear around making a referral to us because, or initiating any sort of palliative supports, because we always think about it as end-of-life care, but it isn't end-of-life care. Again, we're trying to start sort of having a culture shift of thinking about this as something early in disease trajectory. So that's where the gold standard framework comes in. So it's easy for me to say, go out there, start identifying these palliative patients in your practice and, do what I do every day. I mean, it's, I spend, a lot of time with my patients, and sometimes in a busy practice, it's very difficult for you to do that. And so this is where the gold standard framework came from, and this is from UK, and it's sort of a framework to help us identify patients in a practice who we think would benefit from palliative care, and then it gives us the tools that we can use during a practice to help these patients get the care that they need. So the gold standard framework is made up of sort of 4, I kind of say it as 3 steps. It's identify, I think that's the crucial step, is we need to identify those patients. These end-stage heart, end-stage lung are kind of going unidentified. I think cancer oftentimes is a little bit easier for us to sort of recognize. We want to assess these patients, so we want to do pain and symptom screening. We want to look at distress. We want to look at their values, preferences, have crucial conversations with them, and then we want to have the ability to manage them. So if you look at the average family practice, there's this 1% rule. So 1% of your practice will die, okay, each year. So another way of looking at it is 1% of your practice may die in the next year, right? And so if we knew who that 1% was, if we knew who those high-risk people were, and we actually initiated some of these supports, would it make a difference? And what the studies are saying is yes, it would. And so if you look at your GP's general workload, it's 1% of your patients going to die every year. 1/4 of those are probably cancer, 1/3 are organ failure, and 1/3 are frailty. Now, I know everybody has, if you have a pediatric practice, it's going to be very different, or if you have a geriatric practice, it's going to be very different. But this is sort of the average practice. Very few are sort of dying of sudden death. So that's what we need to do, is we need to figure out a way to recognize those patients that have the risk potentially dying in the next year, because those are the highest risk. So, I can say palliative care is good medicine, right? So, I can say to you, you should practice palliative care with all your patients, right? But there are obviously patients that are higher risk, that, these patients that are going to die in the next year, their trajectories are going to change quickly, and you might need to move resources and stuff quickly. So we really want to make sure we identify them. And so there are 3 triggers that we use now to identify patients. So the first trigger is just the surprise question. So would you be surprised if this patient were to die in the next year? And if you say yes to that, then I would say it's time to initiate a palliative approach to care, okay? But, it's easy, that's kind of hard. When you get these end-stage lung, end-stage heart disease, I think it's sometimes very hard to figure out where they are in that illness trajectory. So then there are actually other indicators, and I've put this out. So there's a couple of handouts on each table. So this is sort of the framework that is being used. So then there's these general indicators like albumin below 25. There's increased use of lack of independence. Those kind of things are just sort of general indicators. But then they actually go into disease-specific indicators. So you can go to lung. If you've got someone who's got lung disease, you can actually go and look at actual specific indicators, and that would tell you whether they're high risk for dying within the next year. And so those are the people that we really want to kind of pick out from our practice and say, okay, you know what, we need to look at these in sort of a different light, look at them and start screening them for just symptoms and having crucial conversations with them. So this is sort of the algorithm that's been established, and then again, with this is these sort of for each disease sort of indicators that would help you make these decisions. And then once you've identified them, we flag them in our EMR, or we flag them, we know these are people at high risk. Maybe we'll bring them in more frequently. We know these, with the cancer patient, we can actually predict their trajectory. Cancer patients sort of do well, and then once their functional status goes down, they're gonna go down pretty quickly, right? And so we know that these are patients that we need to maybe see more frequently. We need to screen for symptoms. We need to screen for psychosocial and spiritual needs. And there's tools to do that. So it's not that you need to, it doesn't have to be a long visit, right? There are tools to help us with this. And so one of the tools is ESAS. So ESAS is a standard tool that looks at sort of 9 of the most common symptoms. And then it gets patients to rate them, from no pain to the worst pain ever on a scale of 1 to 10. And what's great about this is that the patient does it, so it's not added work for you. While they're in the waiting room, they fill it out. It also allows you to track symptoms over time. So if you've made a change, so if you've put somebody on pain medications and you want to see if it's made a difference, you can actually track it over time. But it is just a screening tool, right? So it's not the be-all, end-all. It means that if you see numbers above 4, you really need to do a further assessment. So if I got an ESAS and it had pain as a 7 and everything else was low, I know I need to go in and ask more questions around pain. So it allows you to hone in on where you need to concentrate your screening on. PPS is another important tool. So this is looking at functional status. And this is very important in the cancer population because we know patients that are 50%, when they reach a 50%, their likelihood of dying, they have an increased likelihood of dying in the next 3 months. So if you've got someone who's at a PPS of 50%, you need to be following that patient more closely. You need at 60%, I'd be initiating CCAC. I'd make sure that they've got some resources in place. And then plan and manage. So there are also tools in terms of management and planning. If you go to the CCO website, they've got tools. So for each of the 9 symptoms that is on ESAS, we've got tools that actually tell you how, if you've got a person who scores a 5, you know, what are the next steps that you need to take and what are the drugs that you might want to think about. There's also tools regarding advanced care planning that you can give your patients and then help you in terms of having that discussion. And there's also available actually on the CCO website other tools like EDITH, which is the expected death in the home. So if you're a family doctor and new to doing home-based palliative care, you can actually go get those documents online. We also have billing informations, because if you're following these patients more regularly, there are billing codes that actually can, you can actually tap into that actually compensates you for the time that you're spending with these patients. And then there's collaborative care plans, because oftentimes we're sharing this care with an informal care team. So there are care plans on site. So this is all on CCO website, and it's really disease agnostic. So although it's on Cancer Care Ontario's website, you can use it for non-cancer patients. And really, if you go into tools, it'll say palliative care tools, and then you'll find this whole setup with the gold standard framework. And even the screening tool here is on that website. So if we go back to Mrs. Shum, you know, would I initiate palliative care approach in this patient? 100%. She's a 48-year-old woman with pancreatic cancer, and she's got metastatic disease. If I just go through the algorithm, you know, I would probably at the first question say, would I expect her to live a year? You know, not really. I would also expect her to have a lot of symptom burden, right? So she's going to be somebody that I want to actually keep an eye on. So the second one, Mr. Harris, if you go through the criteria on this, he actually meets the actual for lung COPD, end-stage lung. He's currently on HOMO2. His wife is helping him bathing, so he needs help with his ADLs, and he's had a couple of admissions to hospital. So he's high risk as well. So he's somebody I would initiate, not a referral to palliative care, but I would initiate a palliative approach to his care. So the third one is Mrs. Grant. Well, she's stable. She's got an illness that is, I would say, self-limiting. Like, I mean, she'll die of this eventually, but her illness trajectory is very long, right? So would I? No, not necessarily. Would I keep an eye on her? So she's somebody I would always use this, and each time I see her, go back and screen and see, do I need to have this intensive care with her right now? I would probably still screen her for symptoms. She's high risk for that. So I might still use the ESAS and bring her in for annual physical and do those kind of things whenever she came in. But I don't know if I would put in the sort of intense palliative approach at that point. So I'm going to end with, at some time, in some way, we must all face the end of life. And most of us share a common hope that when death comes to us or a loved one, it will be peaceful and free of pain. We hope to face death surrounded by those we love, feeling safe, comfortable, and cared for. So this is off the Living Lessons website. And really, that's what the gold standard framework is that we want everybody to have that opportunity. We want everyone, so these patients that don't get screened, you know, when we look at CCAC referrals for the end-stage lung and COPDs, they're not getting that care. And so that's what this whole gold standard framework is hoping to look at. So.